Welcome to the Evidence-Based Practice in Identifying a Clinical Problem case study. My name is Denise Page and I'm presenting this case study on behalf of our research team, myself, Melissa Gilroy, Elizabeth Hurion, Lisa Clark and Shelley Wilkinson. This case study focuses around implementing evidence into practice in the neonatal critical care setting and is titled Research into Practice, Early Nutrition. Before we divulge directly into the clinical problem, we should pause and take a look at the background and history of the neonatal critical care unit. Approximately 8% of babies are born prematurely in Australia each year. Mater Mothers Hospital is reportedly the busiest maternity centre in Australia, with just under 11,000 babies born annually, and with over 2,000 admissions to the neonatal critical care unit. And of those, around 240 are born with a birth weight of under 1,500 grams. In the literature, preterm birth is described as a nutritional emergency, making it vital to restore a nutrition supply promptly after birth. The literature states that early and aggressive enteral and/or parenteral nutrition is important to reduce nutritional deficits and has been demonstrated to improve both short and long-term outcomes, such as reduced vulnerability to infection, reduced susceptibility to lung injury, reduced necrotizing enterocolitis, and increased maturation of the gastrointestinal tract and growth, as well as long-term outcomes, including optimizing brain development and intellectual attainment, and improving cell growth and vital organ development, including the cardiovascular system. The nutritional care of preterm infants is poorly studied. After 100 years of research, optimal intakes of energy and protein remain unknown. There are, however, internationally recognized consensus nutrition guidelines called reasonable nutrient intakes, by which the intakes of preterm infants born under 1,500 grams can be measured against. In 2012, we conducted a staff survey to establish a baseline of attitudes and practices around nutrition. 100 staff completed the survey, with more than 50% believing we are meeting nutrition targets for this population. We followed this in 2013 with a retrospective audit of early nutrition on 191 infants born at Mater weighing under 1,500 grams. We discovered that none of the infants met their protein or energy requirements in the first 24 hours of life, and approximately 50% were still not meeting their protein requirement at 2 weeks of age, thus uncovering a major disconnect between the evidence and the staff beliefs and practices. We needed to overcome this evidence practice gap by exploring the barriers and enablers to early nutrition systematically by using translational research methodology. In 2014, we gathered a research team, including a neonatal consultant, the neonatal nurse practice development team coordinator, our senior research dietitian Shelley, and ourselves. We used several implementation frameworks, including the PICO, thematic analysis, the theoretical domains framework, the COM-B system, and the behavior change wheel. Our research question was, in infants born under 1,500 grams, will identifying and addressing the barriers to early nutrition compared to usual treatment result in implementation of new practices and improved nutrition outcomes? In addition to our survey and audit results, we reviewed the current literature and resources. We analysed the parenteral nutrition solution composition, and we observed and mapped neonatal critical care unit processes and conducted semi-structured interviews with senior and junior medical and nursing staff until we achieve theme saturation. We asked 6 non-leading open-ended questions that focused on the patient journey and perceived treatment priorities, bravely avoiding questions that would elicit the responses that we'd expected. We analysed transcripts from 19 staff interviews to identify themes and sub-themes. This involved a line-by-line coding and grouping codes into categories until no new codes could be developed. We used a lot of post-it notes. 15 sub-themes emerged that could be grouped into 4 main themes around decision-making, roles and responsibilities, disconnect between beliefs and application of evidence, and monitoring and awareness. We found that staff remained very focused on airway, breathing, and circulation, even once the baby had been stabilised, resulting in delays in moving on to the next priority, nutrition. We found that the type of ventilation a baby was on influenced the type of lines placed, and therefore whether parenteral nutrition was commenced or not, making nutrition a default decision rather than a conscious one. We also identified that consultant practices were very inconsistent. This lack of consensus resulted in a staff culture of waiting for a ward round to make nutrition decisions. Staff reported that the benefits of early parenteral nutrition outweighed the risks, and while some staff identified the need for more concentrated parenteral nutrition solutions, others had little knowledge of the current solutions and found ordering difficult and time-consuming, especially when the unit was busy. We mapped the 4 major themes using the theoretical domains framework and identified 8 theory domains. These included knowledge, memory, attention and decision processes, skills, professional and social role and identity, beliefs about capabilities, beliefs about consequences, environmental context and resources, and social influences. We aligned these theories of domains to sources of behaviour using the COM-B system, which we mapped out through the behaviour change wheel to psychological capability, physical capability, social opportunity, physical opportunity, and reflective motivation. These were then mapped through to intervention functions, which we could develop the most effective strategies to target behaviour change. These included regulation, guidelines, environmental and social planning, communication and marketing, legislation, and service provision. Our first priority was to get a consensus agreement from the neonatal consultants. This turned out to be easier than we expected. They all agreed that all infants born under 1,500 grams and under 32 weeks would have a line capable of delivering parenteral nutrition safely within 2 hours of birth. To support this, we are creating a nutrition bundle with critical, auditable time points and feedback mechanisms for staff, and we are developing guidelines and training materials and identifying nutrition champions within the unit. With these things in place, we hope to empower all levels of medical and nursing staff to be confident with early nutrition decisions in line with consensus practice guidelines. We aim to make choosing nutrition an easy option, and throughout all of this, we will maintain ongoing communication with staff. Once we have implemented our key strategies and allowed for a settling in phase, we will audit the new practices. Our process outcomes, including line placement and timing, and initiation of parenteral nutrition within 2 hours of birth for infants under 1,500 grams, will be reported through the Neonatal Critical Care Unit database, BOB, or Babies on Board. Our clinical outcomes, including protein and energy in the first 24 hours of life, time to regain birth weight, and weight centile at 36 weeks corrected gestational age are now calculated as part of routine clinical care and entered into a neonatal dietetic database for quarterly assessment and feedback. Where to from here? 2017 will be another busy year for us. We aim to implement the Neonatal Consensus Nutrition Guidelines, the new Neonatal Parenteral Nutrition Solutions, nutrition bundles, and we aim to work towards the development and implementation of the e-learning, orientation, and training programs. The light and the dark. The light, what we learnt. Research is timely. Things take much longer than we could have ever possibly imagined. And we also learnt that the problem is not always obvious. In our case, infants were receiving nutrition based on the ventilatory support that they required, not by their gestational age at birth or by their birth weight. And the dark, what we would never do again. We would never assume that we know the solution to a problem without clearly examining the issue first. Thank you for your time, and thank you for listening.